system needs healing. Free to Care has real solutions. Our mission is to magnify the voices of the patient and physician. We want to take medicine back to its original purpose. Join host Dr. Nikki Johnson for Free to Care, the podcast, for conversations on lowering prices, making prices transparent, personalizing medical care, taking bureaucrats out of the system to bring you more choices for your healthcare dollar. We know that healthcare is personal, not partisan. Join us live Fridays at 8 p.m. Eastern for Free to Care, the podcast. Well, good evening, everybody. It is Friday night, August, where are we? 13th. It's Friday the 13th. And this is episode 8 of Free to Care, the podcast, where I am your host, Dr. Nikki Johnson, and I am here to let everyone know what Free to Care is, what it's about, and to teach you how to empower yourselves to advocate for your own healthcare, your own family's healthcare. And we have begun this series with introducing all of the members of the Free to Care Coalition. Today's guest is Terry Wilcox, the co-founder of Patients' Rights Advocate, correct, Terry?
No, Patients Rising. Patients Rising. No, I'm
Patients Rising. Oh my gosh.
Patients Rising.
Oh my gosh. Did I put the wrong? Yes, I did. Oh my gosh.
That's okay. I love Patients Rights.
There's no patient rights advocate now. It's Patient Rising. Okay.
It's okay. I love Patients Rights Advocate.
While I'm fixing that, Terry, welcome to the show. Thank you for joining me. Introduce yourself. Introduce Patients Rising and Patients Rising Now, and let me know. Let the audience know what you guys do, how, and anything that pertinent about the organization that you want them to know.
Great. Patients Rising and Patients Rising Now, we're based in Washington, D.C. We're a national patient advocacy organization. We have two organizations because they serve two purposes. Patients Rising is what's called a 501c3. And on the Patients Rising side, we do support, education, and research around access and affordability issues for patients with chronic and life-threatening illnesses, many patients with rare diseases, and those that use the healthcare system a lot and really need it to work. And then on Patients Rising Now side is where we do more of our policy and advocacy. And Patients Rising Now is the organization that's a member of Free to Care, the Free to Care Coalition. Okay. So that's where we do a lot of that work. And we're one of the only real patient groups. Free to Care is a lot of doctor organizations and others. We're a patient group. But it's great. I love it because one of our roles at Patients Rising is to really help to educate patients on ways that they can put together their healthcare. There's ways to navigate what you're stuck with. There's ways to create your own. There's many ways to put together healthcare. It's not always easy. Sometimes there can be roadblocks, but I love working with the folks at Free to Care. I love the fact that they're very pro-patient. They're pro the doctor-patient relationship, which is another thing that's kind of, as you can speak to, Nikki, has definitely gone by the wayside. So in some aspects, and so that's who we are. Patients Rising. Right. Patients Rising Now. We're happy to be here.
Well, thank you so much. Sorry. Let's just introduce yourself a little bit. You don't have any medical background, correct? You did something else before you were doing this, and what were you doing, and then what turned the tide for you and led you down this path?
Well, it's really interesting. I went to Boston Conservatory, so no, I did not go to medical school or anything like that. I grew up in a medical household. My dad ran a hospital in Denver, St. Anthony Hospital. He was a CFO of the hospital system for many years, most of my childhood or most of my teenage years. And then he was a practice administrator for cancer clinics and an osteopath clinic in Denver. So that's been in my life. And my grandmother and my aunt were both nurses. My mom's a dentist. I mean, there's all kinds of medical happening around me, all sorts
Yeah.
of, and I went to school for theater, and I got out, as many do, and realized all I was going to have to do was audition. And I didn't really want to do that full time. I thought
Hmm.
that was boring. It was much more fun to bartend. I'll be honest with you. It was way more fun to bartend than it was to audition. So I was like, oh, that's not good. That's not what I want to do. And I ended up through a series of jobs. I lived in LA, and I ended up mentoring with a woman named Selma Schimmel, who she was a cancer survivor, who had co-founded an organization, the first organization for young adults with cancer in LA, called Vital Options. And I consider her my mentor. I worked with her closely until she passed away in 2014. She lost her battle to ovarian cancer in May of 2014. Though my twin boys were born on her birthday, which was always
Oh,
really made her so happy, because they were born like
oh,
9 months or so before she passed away. And for a while, I sort of fell into the role of being the executive director of her organization for a little while. And we moved to LA, and I really started getting into policy. And I love policy because I realized that's where the change really happens. That's where you can move needles. But I also realized you can't move needles alone. You can't,
what was the issue that made you say you love policy? Was there one issue that was really tugging?
the one, the one issue I think that really drove me finally was coming into the sandwich generation of my own and
yeah,
realizing like the amount of access issues. I think it was finally realizing, and I say this a lot now, that one moment where you realize everybody's covered. Technically, we've got Obamacare, everybody's covered, everybody has insurance. We're gonna have, we've all got access, but you don't have access, and you
right.
can't afford it, or you can't get the medication. And I found that, all through working with especially with the cancer patients. We did a whole series of cancer patients where we interviewed cancer patients across all Mississippi, Arkansas, Tennessee, and seeing sort of the process and what they went through and those access issues that you just don't think about. See, nobody thinks about the access issues if you're healthy, because most plans are going to cover your visit to the doctor and your mammogram or your basic stuff, but they're not going to really, you may have to go through hoops if
Yeah,
you are trying to get
they're gonna cover all
diagnosed.
that.
Yeah, they're going to cover all,
So,
but they're
is
not
there a
going to cut.
patient
But if you have a
story?
rare disease,
Is there a single patient story? And a lot of people like to connect that way. Is there one patient story that really just drove you head first into this?
well, I think one of the patient stories that drove me headfirst into this was Selma's story
Yeah,
herself and her own personal drive. I mean, just watching Selma sort of, I really
losing your
learned firsthand as not being somebody who has a chronic or life. I do actually have a couple of chronic illnesses, but
pain.
life-threatening
Here we
illnesses.
go. We're
So,
back.
oh, did I lose you?
Yeah, we both did. Both of our feeds dropped out, so it might have been my
Oh, okay.
stream. Yeah,
Oh, okay.
we're
I'm back.
we're in the middle of a storm here too. So
Absolutely. And I think one of the driving issues with Selma was watching her, which was also looking at what patients couldn't have. Because with Selma, I got to do international work, international travel, and interview
Mhm.
overseas and learn about the hiccups and things that patients experience in countries where they don't have as much access as we do, and even we're griping about access. So I talk about things a lot in that respect. And you think about those particular when we would come across those patients and those interviews, and we would watch the struggles that they would go through just to get a diagnosis. Like young adults with cancer was a huge movement for me. It was probably my first, that was my first community this space, in the advocacy space, were young adults with cancer. And that community, just the number of stories where they were constantly told, oh, you're too young, you're not going to, you don't need to worry. And then they would come back and have stage 4 cancer. I have to say, I felt like when I was 35 years old, when I was much younger than I am now, and sort of in the thick of it, that I felt like people were dying all around me because I knew so many people in the young adult cancer space. And so, just watching, I mean, I had this woman that I worked with doing her videos. She was a young mom. She had gone through several rounds of grass versus what is it? Stem cell. She'd gone through many things, stem cell transplants, therapies, whatever. Anyway, it was finally, she was doing these letters and these emails to her baby, who was like just 4, her baby daughter. She was reading her 16th birthday emails and letters, and there I went. Okay, here I am.
I can
really
hear you, though.
Those kinds of stories, and okay, good. Those kinds of instances in my early career as an advocate were constant. And so I think that really drove me to have a true passion for the patients that are living. And those are just some of the stories. I mean, I could tell young adult cancer stories and probably be on the floor if I just went back and thought about it. But
can you give me a couple of examples of stories about patients not getting access, or having difficulty getting access, or access to treatments, not just to physicians and and medical care in general. So,
well, I mean, I could talk about a lot of access issues in the more recent. I'll tell you one thing about cancer, is that cancer was my early experience, and and even today I still have. I have a very good friend who runs the Kidney Cancer Coalition, and she constantly tells me, she's like, one of the issues that people don't talk about, is my drug price is too high.
Yeah,
they get the treatment in cancer. They may have to move mountains. The hospital may overbill them, and they may get a bill, and then Cynthia Fisher at Patient Rights Advocate will will yell at them about it. But there's a different attitude there. So where I can talk about is some of the attitudes of the chronic disease community, because this is where you really find yourself not getting what you need, or being just pushed aside.
Yeah.
And this is I'll tell one of my best stories around copay accumulators, chronic illness, not being able to get medicine, insurance company screwing you over, ridiculousness. We have a patient advocate in Texas. She's a self-employed working woman. She doesn't qualify for any kind of subsidies, but she's got to get her own insurance. So she's gone on the exchanges, right? She has a plan that costs over $700 a month. Okay, just for her. She's basically healthy, except for that she has MS. Okay, so her MS drug is obviously expensive. Most of them are. Part of that has to do, as you and I both know, with the ridiculous rebate structure within those particular drugs. And when you look at MS and rheumatology, you can just really see it. It's very clear in those two groups how bad and diabetes. Diabetes is another one, which we can talk.
I have rheumatological disorder. I have psoriatic arthritis, so I am in that category of chronic disease with rheum, and the medications are terrible. Prices are astronomical.
The prices are astronomical, and part of it is, so this is what happens, and this happens all the time to a lot of our patients, is they'll get patient assistance, because when they started putting a lot of the burden of the cost of medicines back on patients and creating these high deductibles, and patients like this particular patient advocate were forced onto these plans because they didn't have any other options, because there was no options left, and they had a chronic illness, so they couldn't just go around and just do anything. They had to find a plan, and so they get their copay assistance that's helping to cover their drug, to cover their copay, and they don't do that. So then all of a sudden you show up at the counter and it's like, that'll be $4,713 or whatever for this particular month. And that's not something we all have on hand. And it's not something you can put on credit cards for very long.
Yeah.
Right? I mean,
Yeah.
let's be clear. So what usually ends up happening in that case is you call the pharmaceutical company, at least in her case, and she ends up getting the drug for free. Okay? Because the pharma companies, as bad as everybody wants to say they are, one of the biggest issues, and I tell them this, and Patients Rising does receive funding from pharma. I'm like, you guys are doing a terrible job at helping us, tell all your stories about the copay accumulators. I said, because you constantly, when the patient's copay accumulator runs out and they still need the drug, you give it to them.
Yeah.
Like,
and so, that is a very interesting point that you bring up, because they do get the bad name, the capital PH pharma. It gets a bad rap a lot, but I try to tell people that, every organization that's part of medical care, has some good and bad. But what we need to be thinking about is, who are the people who are actually producing something that benefits the patients. And
Right.
Pharmaceutical companies are the company that develops the medications, they develop the products, and they do the research, and they do have programs or payment assistance. I get my medications with payment assistance. I couldn't afford it without it. I think what's concerning now is that you just alluded to, that people are hopefully starting to wake up to and learn from, at least by listening to this show, I hope, is, what the people in the middle who negotiate the deals and the contracts with the pharmacies, with the insurance companies, these PBMs, large PBMs, with these secret deals, getting rebates and then not passing that on to the patient. One of the things that is currently a topic, at least locally for me, in some of the insurance companies now are not including medications like these, where the pharmaceutical company will pay, pay or provide some copay assistance, where you're paying $5 a month or $10 a month for these really expensive bio drugs, I guess we'll call them that. They are deciding that they will not count that towards the deductible for patients. So for me, taking my medication by, before half the year's over, I've pretty much met my deductible because of the medications. But now they're not doing that anymore. At least that is the current topic that's going to be changing. Can you talk to?
Yeah, they're not doing it. They're taking
that?
the money, they're pocketing your coupon. And then they're telling you that it doesn't count towards your deductible. So in the case of our friend in Texas, she ends up paying her doctor's cash and not using her plan at all, because she pays, she has an $8,100 deductible and she pays over $700 a month. So basically she has a $15,000 a year catastrophic plan. So if she really did need to use it, it'd cover the emergency stuff, but it cost her $15,000 first.
Yeah.
And it doesn't come with an HSA, so there's none of that that's tax deductible. It's not tax deductible, $8,100.
No.
So they're not even that. So I think it's a real crime, sort of what they're able to get away with here, because the truth is, you were right earlier, there are all kinds of plans that, everyone always says, well, let the free market decide. And by nature, I'm a free market girl, but you and I both know healthcare is so far from a free market.
Correct.
Like, just
correct.
It's just not.
Yeah.
It's just not. I mean, the
U.S.
government is pharma's number one
fair
client.
market. We need a free and fair market.
We need a fair market. If we could have a fair market, that would be at least getting us somewhere. Because, pharma has to pay, the 340B program. I don't know how much you know about that. The hospital drug buying program, where pharma can literally pay, if you're on a drug, let's take a really popular drug, one of the most popular, Humira. Let's take Humira.
Okay.
It can be pennies on the dollar for a hospital to buy Humira in the 340B program. And then they're supposed to be using that to help people who in need. But then you'll find that they'll just resell it to somebody who's got an insurance plan and get like more reimbursement than the 5 cents they paid for it. And I'm not kidding when I say cents, like it's
Oh,
pennies.
wow.
So the 340B program is a huge problem. It's been very abused. The number of hospitals that have become 340B hospitals over the last decade. Ted Ocon at Community Oncology Alliance has done a lot of papers and work on this, and it's really unbelievable, actually. So
Wow.
there's that, and then there's there's the veterans price, and there's the Medicaid price, and there's the, you know, so I feel like it's very, we have a very complex system, and that's why organizations like ours exist. I mean, that's why we have hotlines
Yeah.
to help people navigate whatever sort of care they're going through, and that they're dealing with.
So can you
You know,
be a little bit specific about that? So say I'm a patient, I want to sign up and just I don't know, be a part of Patients Rising. Go to the website and advocate. Website's right there on your screen, www.patientsrising.org. Um, what are the steps for me? So say I'm struggling to find medication or get a good rheumatologist or pay for my medication.
right on the homepage, we have what's called a tab called Get Help. And if you just go to Get Help, it'll tell you everything. That we have an email called Ask Us Anything at patientsrising.org, and you can also call our hotline, which is on that page, and they will, literally, you can ask us anything. And I'll tell you what our number one issue is right now that patients call us with, to be honest, is transportation. It's one of the biggest things that we help
Hmm.
support is patients actually not having transportation to get to treatment, or needing caregiving, or needing assistance in the caregiving space. Caregiving is big, and caregiving is something that gets really overlooked by many. In this space, and
Hmm.
there's not a lot of consideration often for them. Of course, we also get the other things. How do I navigate this plan? How do I pick a plan? How do I even talk to my insurance company? They denied this. There's many things that we can help them. How do I appeal? We can show people how to, write their state insurance commissioner if there's a reason for doing that, if what the plan has done is egregious or whatever. But we help them with whatever issue that they have, and we try to help them till we're finished. We don't say that we're probably the last stop on your journey to getting what you need, but we want to give you really good directions so that your next call is hopefully it. We're the direction giver, so you're not just like Googling into the abyss of like what could possibly be, because it is a lot. And when you're stressed and sick, it's really a lot.
Yeah.
It's
Yeah.
really a lot.
Do
Um,
you
it's
do you have anything for patients who have chronic illnesses who right now don't really need anything, any resources that they could at least join and find or connect with someone who can be that sort of a support system when they do have a crisis, or is it really
Well, one of
mainly
the
like
best things
putting the
that we have
fires
at
out?
Patients Writing, well, it is that, but one of the things, our Facebook community, we do have a Facebook community that's actually pretty active, where you'll find a lot of that. We also have, um, on the advocacy side, the Patients Rising Now side, which you can get to from this website as well. We have an advocacy training program. It's a 14-week patient
Hmm.
advocacy training program where you really learn about policy and advocacy happening now that affects patients, not just at the federal, but the state level. And our goal for this program is actually to have 10 patient stories in every district in the United States by 2025. And what I mean by stories isn't
That's
just somebody
awesome.
who's I've fished for in Google and they've given us their story, but actually relationships, like people that are communicating, and we're making change at the state and local and federal level by this group. Because we just started the program this year. We trained 57 advocates, I think, in the first group. and those advocates, many of those are now mentoring the advocates who are in the second group.
Wow.
And we hope to do that. We're starting another group in the fall, so everybody can know they can go there. We're signing up for the fall, the last session of the year, which will start in September. It's
Are these
free.
virtual
It's
sessions,
really
Terry?
comprehensive.
Are
They're
they
all
virtual?
virtual. They're all
Okay.
virtual. They're all virtual. A lot of it's self-directed. We have really great video and self-directed, but it's also several live sessions if you can attend them, and they'll be recorded if you can't. And then also a constant ongoing community where you can ask questions and engage. So that's the really great piece of it. And we're hoping to have a community in every state. Like, that's the real goal.
That's fantastic. I mean, that sounds so exciting. that sounds like a big force of like the people rising. I love it. Patients rising. That's awesome.
That's the goal.
Right.
That's what we do.
Can you tell me legislatively, at federal level, state level, whatever, what's your biggest accomplishment, or what's the biggest accomplishment of the organization, you'd say?
Well, I'll say it this way. Our biggest accomplishment is helping bring patients' stories to the forefront. We are 6 years old this month. So we are on several coalitions for step therapy, for copay accumulators, for all sorts of coalitions. And we work really hard on those coalitions, and there have been successes from those coalitions. Would I credit Patients Rising with that? No, we are not large enough or to be heading legislation per se, but we can advocate on behalf of legislation. And we do that. One of the things that we do a lot of is we inform patients. I don't know how much this audience really knows about the Institute for Clinical Economic Review, which is ICER.
Totally not.
But I'll tell you guys a little bit about it if you want to know.
This is an audience of patients. There's some nurses and doctors who listen in too, but these are people in my Twitter feed who are mostly non-physicians who join us.
Okay.
Who join in.
All right. Well, great. Well, that's good. These are the people that I want to talk to. Okay. So President Biden gave a speech yesterday about drug pricing, which was, I wrote a comment about it. You can read it on the website. I'm not going to read it here. I didn't love a lot of it. But one of the things that's mentioned in it is that they want to have a group to provide frameworks to tell everybody what a fair price is for a drug. Okay. That's really scary word. That should scare everybody, in my opinion. It should scare everybody, in my opinion. A group? What group? Well, the one group we have in the United States, a group of who? A group of who is going to be doing that? So it's not, oh, honey, I'm on, say hi to Jackson. This is my son. Okay. All right.
Okay, congratulations on finishing Taekwondo.
Yeah, honey. Okay, you can sit right there. All right, I'm sorry, I'm back. I'm the mom of twins. They're going to be 8 soon. He's going to be really quiet.
Making noise in the background.
But the Institute for Clinical and Economic Review is an organization based in Boston, and everybody should know about them, and they should be scared if they become any part of the of the government, because they're not. They put out these reports. It's probably too complicated for me to go deeply into, but basically, if a new drug is approved by the FDA, they decide they're going to do what's called a review of that drug. And then they do this framework. They use a metric that's called the quality adjusted life year, which is historically discriminatory and against the disabled and the elderly, really, especially. Because basically it values your life. If you were not in perfect health, it values your life as less than 1. So nobody should be worth less than 1.
Right.
That's the simple form of it. And, they've made a lot of headway. They got a huge amount of funding from a fellow by the name of John Arnold, who is a billionaire who hates pharma. He also hates pensions. There's a few things he hates, and I think we're back. Okay.
Yeah, you're in and out just a little bit.
But anyway, John Arnold has funded. Okay. They got about $20 million worth of funding, and it has really put them on the map. So, to just in a nutshell, ICER is something that we do talk about a lot. We are very active in trying to make sure that we find other ways, if we're going to be measuring and telling people what drugs they can and cannot have on any kind of national formulary, should we ever get there, which, I don't hope we're ever in that position where there's no other options. If we have I said this today, I had an interview today with Wendell Potter, who is a whistleblower from the insurance industry on our podcast, Patients Rising podcast. And, Wendell is a very pro single, not, he used to be more, he would say Medicare for all and single payer, but now he's come to a public option. There should be a public option to keep the insurance companies honest, because he's got a lot of knowledge in that space. And I am right there with him on that. It was a fantastic interview, and he's a great guy. And my best hope is, okay, if we get there and we have a public option, I just hope we have all these other things that we can have, that people can still choose. If they want to have direct primary care, they can have direct primary care. If they want to have this or they want to have that, they can do all of whatever it is they want to do. I don't ever want us to get to a place where we're stifled as a country, so that it stifles innovation and it stifles choice. And it stifles what patients can and can't,
my concern
what decisions they can and can't make for their own health care.
Yeah, well, that's my concern about offering a public option, because who's not going to want?
I see. I want to hear it from you guys, because all of my free to care friends are like, you're a direct primary care. You do your thing. So what is I don't want to turn the tables. I know I'm not asking the questions, but but what is the fear? What's the fear of the public, if there is just like a public option for, people who can't afford the ridiculous Obamacare price, if their state doesn't have, subsidies? What is that? And how do we educate on these things? Because I'm curious. I like to know. It's what we do.
Great question. Yeah, and I think that, well, I'm one of those people that I kind of need to see it mapped out. And my vision of having a public option is, you have all these options over here where I have to work for it, spend my own money to get the things that I need for myself and my family, and the costs are this. If the costs are here, wait, here's the camera. If the costs are here, then that's scary to me, especially if I am lower middle class, even middle class these days. Sure, I can pay for a regular visit, a well visit, couple labs, an X-ray here or there. But if I, have an illness where I need to take medication all the time, that's a lot of money. If there is option A or option B dangling over on the other side, and the costs are up here with what's available outside of the public option, I'm gonna go ahead and pick the public option. If the costs are where they should be, where you and I think they should be, pretty much at the actual value, with, sure, the pharmaceutical companies, the hospital making some sort of a profit. I mean, they have to stay in business. Doctors actually have to run their practices, so we have to and pay people, and that it's absurd to think that people who have a trade, which is what medical care is, can't have make a living off of it. So if you then you're going to get some people who will choose the private personalized option, but most of the people are going to pick the public option. The second piece of it is that Americans are we're used to one way. For the last 40 years tops, maybe we have had managed care, where someone kind of puts it all in a bucket for us. And you have these health plans where someone kind of lists all the things, and this is what I know I have to pay when I do this. And people like that. They like knowing what they're going to get. They don't want to not know. Direct primary care is I'm a huge fan of it. I mean, if I had the opportunity here to do that, I would definitely do that. I have a high deductible plan. I do have an HSA with it, and I do try as much as I can to pay, out of pocket. But not everybody who's employed knows that they have that option to use
Right.
direct primary care. And that's a concern. And then the people who are getting Medicaid or Medicare can't always use that option either.
Well,
So
and a lot of things
that's a
also,
concern. It's a mixed bag.
There's a big concern. I mean, in Israel,
Mhm.
the co-host on my podcast, Israel has a real, they have a public option, and then they have alongside it like fee for service, all this other stuff you can do. So it's like
Yeah.
you can still like do your own thing in Israel, and you can have this. But my fear is that, to your point, we have all these weird buckets. And so if we create this I would be curious how direct primary care fares in Massachusetts. Massachusetts has a public option.
Yeah.
So
well, see, that's the thing too. We're a republic. So why can't states do what they want to do differently in localities?
I think there is a big push for that. And Wendell actually talked about that in our interview, that we may or may not get a public option. Jackson, that's really driving me nuts. Sorry.
Yeah.
So we're really getting it through at the federal level, but it's difficult to that's difficult. It's a difficult push. Whereas, if a state wants to do it, a state can do it, and states are exploring it. States are exploring it, and they may, do that, and it'll be interesting to see like how we fare around it. So at Patients Rising, we're open to all conversations that help patients. We just want to be part of the conversations that are deciding, okay, if you create a public option, are patients going to have access to medications they need? Are you going to make this really restrictive formulary are you not going to let them get their medicine? Are they not going to be able to get assistance from pharma then? Or are they?
Right.
There's many questions. It's not so
the
easy.
Physician that they want.
They want to see. Can they see can they keep their doctor? That wasn't true last time.
Right.
We have a semi, you didn't get to keep your doctor. And so these are big questions. They're burning questions for this whole process. And we have a complicated healthcare system. And I do think that we have a great healthcare system in many ways. I know we have a lot of great doctors, hospitals, research. I have confidence in our ability to innovate and figure it out. I actually really do. I'm very optimistic on that front. I just, if we would stop being so partisan and yelling at each other and saying that and I don't mean partisan Democrat or Republican, I mean just partisan in your belief of how the healthcare system should be.
Correct.
And let's figure out like what it needs to be on behalf of the 5 to 10% of patients who really need it to work.
Yes.
Or I'm not going to say
no
patients.
one right answer.
The 5%, 10% of people who are the most expensive, who really need it to work. We need to work backwards. We don't need to work with lowering my mother's premium in her Medicare Advantage plan.
Correct.
Trust me, she doesn't need to save. My mom doesn't need to save $5 in her Medicare Advantage plan.
Yep.
But I know a lot of people who really need help in this other space.
Yep. So cute.
So I think I'm coming up on my limit here pretty soon. I think I've got the other one, but the other one's coming. Okay.
It's so sweet to see those little faces. And you want mine are just like slamming doors around here, just trying to keep the puppy from getting at everything. So I'm glad that we ended on a positive note. That's the best. That's the point of this, is like, what is the solution? And what can we do for ourselves as the people of this, huge, magnificent republic that we have. And Patients Rising and Patients Rising Now has the tools for people who have chronic illnesses and need some assistance, and can show you how to advocate for yourself. And that is what Free to Care is all about as well. And that's what this podcast is about, is to try and get you that information, where to log on, how to help and advocate for yourself. You see people going to town halls and going to their school board meetings and advocating for their children. And that way you can do the exact same thing for your healthcare. So thank you all for giving us your time this evening. Terry, thank you so much for coming to join us.
Thank you.
And I can't tell which twin is which, but
I got a redhead and a blonde. So they're both surrounding me right now.
I'm missing it because
This
I'm
is
looking out of the
James.
corner of my eye. Okay, that's the redhead back there.
That's the redhead.
All right, who are Taekwondo black belts now? What do we do?
Taekwondo, they're brown belts. They're brown belts. They're brown belts. That's nice. So it's good.
Oh, fantastic. That's
They're very
fantastic.
excited.
I have my yellow belt. All right. Thanks, Terry. Have a good night and have a great weekend.
Thank you. Thanks, Nikki. Bye-bye.
Bye.